So supervised injecting facilities, that's the term I'm going to mostly use throughout this presentation, but they're also referred to as medically supervised injecting centres, heroin injecting rooms, safe injecting rooms, drug consumption rooms. They're defined as legally sanctioned places where people can inject or consume using other methods their own pre-obtained drugs under supervision. There are more than 100 supervised injecting facilities operating at the current time. It's actually very hard to keep up with the numbers right now because particularly in the last year, there's been quite a rapid escalation in the number of these facilities in Northern America, in particular in response to the opioid crisis there. But the 10 countries include Switzerland, Germany, the Netherlands, Spain, Australia, Canada, Norway, Luxembourg, Denmark and France, approximately in that order. The first formal legally sanctioned room being established in 1986 in Bern in Switzerland. They're mostly located in urbanised areas where open drug scenes had developed in association with the concentrated supply and use of illicit drugs. Places such as red light districts, such as King's Cross in Sydney, Australia, or in transport hubs, railway terminals, seaports, and often all of those things occur in the same place. Open drug scenes are public areas with high prevalence of drug-related activity, and what we know about when people inject in open drug scene situations, as I say, mostly in city situations, there are particular public health issues such as fatal and non-fatal overdoses. People tend to be injecting quickly because they're in public situations, so it's not in a controlled sort of a way. It's usually a high-risk part of the injecting population that is street-based, and that in and of itself increases the risk behaviour. So also associated with increased risk of transmissible infections such as hepatitis B and C and HIV. And we also know that this more marginalised, street-based, often homeless group of people have poor access to health services and the health system more generally. Open drug scenes are also associated with public order issues, and we include there high visibility injecting, which affects amenity, makes people in that area feel less safe and secure, and also with discarded equipment. Often, as I mentioned before, it's done in a fairly rushed way. People worried about apprehension, so often leave behind injecting equipment, which also, of course, affects public amenity in those areas. Supervised injecting facilities are considered to be a balanced approach to injecting these public health and public order issues. They are good for the health of people who inject drugs, and as mentioned already, they improve public amenities. So in this sense, they're a win-win type of a strategy. There are other ways to deal with high concentrations of drug use in public areas, such as zero-tolerance policing strategies. While they may improve public amenity in that immediate area, they tend to just displace the activities, and in so doing are, if anything, detrimental to the health of people who inject drugs. So those of us with a public health objective think that injecting centres are a better way to deal with open drug scenes and the problems associated with them. Supervised injecting centres are probably best framed as an extension of the needle syringe program. I'm quoting here the recommendation of a Royal Commission in Australia that was held in the middle 1990s. And the final report handed down by the Justice who oversaw this Royal Commission, he stated that at present publicly funded programs operate to provide syringes and needles to injecting drug users with the clear understanding that they will be used to administer prohibited drugs. in these circumstances to shrink from the provision of safe sanitary premises where users can safely inject is somewhat short-sighted. The health and public safety benefits outweigh the policy considerations against condoning otherwise unlawful behaviour. So you can see there he clearly saw it as an extension of the needle syringe program, that to provide a clinical, safe, legal space, and in this sense it could be seen as accepting a duty of care that existing needle syringe programs don't necessarily do. As referred to here, we give needles to people with the objective of reducing the risk of bloodborne infections, but we know that those people walk out of needle syringe programs and then inject somewhere, and we don't take responsibility for that. Unlike injecting centres where they say, okay, rather than going outside to an unsafe place, why don't you inject here in a clinical setting where you'll also be able to be assisted in the event of a medical emergency such as an overdose. You can get prompt, effective treatment, as well as being further engaged with healthcare workers with the longer term objective of channeling such people into appropriate treatment and care as considered necessary. The evidence base. A systematic review of 2014, published in Drug and Alcohol Dependence, looked at 75 relevant articles. Notably, 85% of these published articles were emanated from the Vancouver and Sydney injecting rooms, which were both established as scientific trials with a team of highly qualified researchers evaluating all aspects. So even though more than 85% of the literature concerns these two facilities, and all of the studies converged to find that they were efficacious in attracting the most marginalised, street-based, homeless, often engaged in sex work, injectors. They promoted safer injecting conditions, reduced drug overdose frequency. In particular, the Sydney room found that since its operations, the number of ambulance call-outs to the immediate vicinity decreased 35% more than it did in a neighbouring suburb. And interestingly, the Vancouver room did a similar study and found exactly the same proportion reduction in ambulance call-outs to its immediate vicinity. They also enhance access to primary health care, particularly Vancouver room was able to demonstrate through a nicely designed cohort study that those people who had accessed the room as opposed to those who hadn't were at least 30% more likely to be referred to drug treatment and rehabilitation services. They also reduced levels of public drug injections and discarded syringes. They were not found to increase drug injecting, drug trafficking or crime in the surrounding environments. This so-called honeypot effect is often an argument used against locating facilities in particular areas, but there has been no evidence that they've had that sort of honeypot effect. But it should be noted that the impact of these facilities is very much in the immediate vicinity of such facilities, possibly limited at a population level, depending on how many you have. When you start looking at countries like Switzerland and Germany that have and the Netherlands, which have had sort of 20 or so operating, then maybe you've got some hope of getting the sort of coverage that methadone and needle syringe programs have had, but otherwise their biggest impact is in their immediate vicinity. But that's not to be that's still an important thing, because in these open drug scene areas, it is in that immediate vicinity that there is such a high concentration of problems. They complement rather than replace other harm reduction measures. Often I'm asked, but isn't a heroin prescription program better? These are not the same thing. They work very well together, and as we see in places like Spain, Canada, the Netherlands and Germany, they coexist with heroin-assisted treatment programs. The future, there are continuing calls to expand, particularly as I referred to before in North America. Canada now is expanding very rapidly the number of injecting centres right across the country there. United States is talking about it. San Francisco just last month opened a mock facility so that people could actually have a look at the physical space. They're not actually operating it, but hopefully that will demystify what an injecting centre at least looks like. Pennsylvania, New York are other jurisdictions that are very close to possibly opening, although the Attorney General of the United States has said that they will quickly introduce federal legislation to override any state legislation enabling such facilities. Meanwhile, though, I think it's very interesting to note that, and I'm sure the next speaker will refer to this too, that particularly the Netherlands and Switzerland, which were the forerunners of this approach, are now reducing the number of supervised injecting facilities from a very high base, as I referred to before, due to decreasing numbers of injections. A speaker yesterday from the Netherlands mentioned that there are 120 injecting drug users in Amsterdam. That you could put a number on it like that is an incredible thing, I think, having been around for a very long time. They've ceased surveillance of things like hepatitis C because they're just not getting new infections. So that's a fantastic outcome after all this time. It's important to note that those two countries, I think, of all countries, arguably, were the ones that achieved the highest population coverage of harm reduction type interventions with early introduction of the full spectrum from low threshold needle syringe programs, supervised injecting facilities, opioid substitution treatment, and including heroin assisted treatment. They also effectively depenalised drug use, have prison drug diversion programs, and in the case of Switzerland also have needle syringe programs in some prisons. So it could be argued that what I'm referring to as a sort of carpet bomb saturation approach has successfully turned the tide in relation to injecting related harm. And this has important political advocacy implications, I think. It also has implications for the appropriate timeframe to be evaluating harm reduction initiatives more generally. The Injecting Centre in Sydney was established to be evaluated across an 18-month period. It actually ended up being a 9.5-year trial, but I won't go on further about that. But clearly, those sorts of timeframes are insufficient to really assess the impact of this full throttle approach. It suggests that maybe decades are needed rather than years, let alone months. But particularly, I think at a political level, it can be reassuring that going down this track isn't necessarily a one-way street, that things can turn around as has been shown. So that's it from me. I'd like to now introduce, what we'll do is we'll keep questions to the end of the session. So I'd now like to introduce